So, welcome friends to the SOLACI-SBHCI Congress 2019. I have the pleasure to be here with Dr. Thomas Modine, which is an interventional cardiac surgeon from Lille, France, and also from a university in China. If you allow me, I will read this, Jiaotong University in Shanghai. It's his first time in Latin America, I believe so.
Absolutely.
And it's my pleasure, and also from our colleagues, to have you here, sharing all your expertise in structural heart disease. So, Dr. Thomas, I will ask you about particular patients that doesn't have a good access, femoral access. How now you approach those kind of patients?
So, Tavi has become in the last few years a gold standard treatment with very effective results, which has proven its superiority not only in high-risk patients but also in low-risk patients. The problem, there is always a percentage of these patients who have difficult femoral access, which could jeopardize the quality of the results of the TAVI itself. And in this percentage of patients, which ranges between 10 to 15%, using an alternative access, which is another access than the femoral, provide the patient safety and efficacy with the TAVI. So, and we looked at all the different access other than the femoral, and we tried to assess the safety and the feasibility. And it shows today that the vascular access, subclavian and carotid, are a very safe and very effective access for TAVI that we have to consider very carefully in any patient in whom we consider femoral access is at risk.
So, talking specifically about carotid access, I believe you were the first to perform a TAVI via using this access. How did we come to this?
Yes.
Where did you get this idea from?
Sure.
And which evaluation you perform in the patient to see if it is suitable? And every valve, every prosthesis is suitable to be implanted by the carotid access.
So we have been believers in the TAVI success since the very beginning, but we have been facing a lot of complications. The patient also were facing a lot of complications because of the femoral access, sometimes difficulty. And we had one patient one day in whom femorals were not suitable. The patient was old enough not to be able to support a general anesthesia and have a direct aortic or transapical access. The patient also has a history of endocarditis and infection of permanent pacemaker need. So both subclavian access were denied. So we thought at that time, if we can use the subclavian, we can use another artery. And the closest artery was the carotid access. So we did the first case with the carotid access in 2009. Under local anesthesia, and we published on this. And we discovered immediately that this is a very easy access, very safe access, and the artery is very good quality, usually at the level of the common carotid artery. And this was the first patient, and it opened a wide range of applications for TAVI for these patients. I can tell you today, the carotid access is the first access in France after the femoral, and it's the first alternative access used in China, for example. And more colleagues are using it because it offers the advantage of being fast, being easy to learn. You can do it under local anesthesia, and it's very comfortable with the patient, and it gives exactly the same quality of results as femoral. Of course, this is not supported by randomized controlled trials, but the observational studies that we published and we reported, and the global experience shows that this is really a very good alternative access.
And have you done this with balloon expandable and auto expandable processes?
This is the beauty of this access. You can do it with any valve. Okay. So all commercial available valves for Tavi. We tested them for the scouted access.
So since you have already resolved any issue with Tavi, let's talk about mitral replacement. What do we have to do? What we have to address? Are the results? Are you happy with the results? Which challenges we still have ahead of us?
Sure. So, I mean, the history repeats itself, and one of the motivation behind a driving force behind Tavi is that there were some patients with unmet needs. We had a lot of patients which were denied for surgery. Some patients didn't come to surgery, and some patients who were operated with not always the quality of outcomes that we could expect. And I'm not talking only about immediate outcomes, but sometimes during follow-up, we discovered that some patients do not recover. And this was the main driving force behind Tavi, and the easiness of the technique and the improvements, both from the clinical side and the industrial side, engineering point of view, helped us being where we are. But we felt that what we applied for Tavi, we could replicate it for mitral, and hopefully in the future for tricuspid, because you have epidemiologically, we have much more patients suffering from mitral disease than aortic stenosis disease. So we know that there's many patients out there that are suffering, that are experiencing heart failure, that are not sent to heart centers or surgeons to be operated on because either they are ill or they are very old. And I think people underestimate the impact of this number. I'm not talking about operating more patients. I mean, you have to keep in mind that a heart failure patient related to the mitral, if you can treat him, you will avoid him being readmitted to the hospital and with additional costs that we don't estimate. So I think it's very important. And what I've learned from TAVR experience that many limitations are related not to our experience, of course, but also to the amelioration of the devices. And with the mitral today, we are in the beginning of the journey. So, and I am sure in the future with this discussion with the engineers, we will have better devices and we will be able to treat mitral valve disease exactly as we do it for surgery. It needs time. We will be able in the future to repair the valves or replace the valves, but it will be easier, faster, and quicker. And this is very important.
Well, we hope we see this in near future, and we hope to have you here again in the near future to share all this information with us. Thank you very much.
Thank you very much. Thank you for inviting me. Thank you.